His name was Franklin. He was 74 years old, a retired high school math teacher from Columbus, Ohio. He had coached his son's baseball team for 11 seasons. He had a vegetable garden in the backyard that he tended every spring without fail. He drank 2 cups of coffee every morning, black, no sugar, and he read the newspaper the old-fashioned way, folded open on the kitchen table. His wife of 49 years used to say he was the most predictable man she had ever loved. She meant it as a compliment. On the morning he died, she was already downstairs. She had heard him moving around upstairs the way she always did. She had started the coffee the way she always did. She sat down at the kitchen table the way she always did, and she waited. He did not come downstairs. His physician had examined him 6 weeks earlier. His numbers, all the ones that get checked at annual appointments, were acceptable. His blood pressure was elevated but manageable. His cardiologist had noted mild arterial changes consistent with his age and told him to watch his diet and keep walking. He had walked out of that office feeling reassured. He had every reason to feel that way. The problem was not what was in his chart. The problem was something that happened every single morning in the first 10 minutes after Franklin opened his eyes. Something so ordinary, so woven into the fabric of daily life that it had never once appeared in any medical conversation he had ever had, not in 74 years, not once. There is a specific window in the early morning hours that cardiovascular researchers have studied for decades. A window in which adults over 60 are statistically far more likely to experience sudden cardiac death than at any other point in the day. Not during sleep, not during exertion, in the first hour after waking. And in that window, there is one particular action that millions of people over 60 perform every single morning that amplifies every risk factor simultaneously. Nobody ever explains in a standard medical appointment, and that most people would never in 1,000 years identify as something connected to their heart. My name is Dr. Michael Hardee. I am a cardiovascular internist, and I have spent more than 2 decades working almost exclusively with adults over 60 who want to understand not just what their numbers say, but what is actually happening inside their bodies each day. I am going to explain to you in this video has a specific medical name. Most people have never heard it. Most physicians never bring it up unprompted. By the time we finish, you will understand exactly what it is, exactly what it does to your heart in the early morning, why the risk compounds significantly after 50, and one completely free adjustment you can make tonight that changes what tomorrow morning looks like for your cardiovascular system. Stay with me through the entire video. There is something I explain roughly halfway through that most people have never been told, and that is the part that tends to matter most. Before I tell you what Franklin was doing every morning, I need to give you one piece of foundational information, because without it, the mechanism I am about to describe will not make complete sense. Your body does not transition from sleep to waking gently. That is not how your physiology works. Beginning around 3 or 4 in the morning, well before your alarm, your adrenal glands begin releasing cortisol. Your blood pressure starts climbing toward its highest point of the day. Your heart rate begins to rise. The proteins in your blood responsible for clot formation become more concentrated and more reactive. Your entire cardiovascular system is mobilizing for the demands of an active waking day. By the time most adults over 60 are standing up and walking toward the bathroom, their blood pressure is at or very near its daily peak. Their blood is thicker than it was the night before, concentrated by 7 or 8 hours without any fluid intake. Their clotting system is fully activated and sitting ready to respond. This is the physiological window your heart enters every single morning. And after the age of 60, Three structural changes in your body narrow the margin between that window being manageable and it being genuinely dangerous. The first change is in your arterial walls. As you age, the elastic tissue inside the walls of your arteries gradually breaks down and is replaced by collagen. Your arteries become less able to expand and recoil with each heartbeat. Instead of absorbing and dampening pressure waves, transmit them. A spike in pressure that a younger, more flexible arterial wall would have absorbed now travels through your entire vascular system with far more force than it did 20 years ago. The second change involves your baroreceptors. These are the pressure sensing mechanisms embedded in your vessel walls that detect changes in blood pressure and signal your body to compensate. After 60, they respond more slowly. The corrective signal arrives late and with less precision. Cardiovascular system has less real-time agility than it once did. The third change is in overall autonomic speed. Pace at which your heart and vessels make moment-to-moment adjustments has decreased. What a younger cardiovascular system could smooth out in a few seconds now takes longer or does not get smoothed out at all. These three changes do not make the morning dangerous on their own. What makes the morning dangerous is what most adults over 60 add into that window every single day without ever realizing it. It is called the Valsalva maneuver. Most people have never heard that term. Most people over 60 are performing one every single morning, and almost none of them know what is actually happening inside their bodies when they do. Let me explain exactly what the Valsalva maneuver is, what it triggers inside your cardiovascular system, and why the risk it creates grows more significant with every decade after 50. The Valsalva maneuver is the act of sealing the airway, holding the breath, and bearing down with physical effort. In everyday life, occurs most commonly and most consistently during the effort of straining on the toilet. Most people perform it without any awareness at all. Feels like nothing. It is so instinctive, so reflexive, so completely automatic that the idea of it carrying any cardiovascular significance has simply never entered the conversation. But inside your body, it is anything but insignificant. There are two distinct phases, and both of them matter. In the first phase, the straining phase, when you close your airway and bear down, the pressure inside your chest cavity rises sharply. That pressure bears down on the large veins running through the chest, the vessels that carry blood back to the heart. Those veins are compressed, the volume of blood returning to the heart drops. The heart detects the reduced input. It responds by accelerating. Pressure spikes. And at the exact moment, the heart is working harder and demanding more. The coronary arteries, vessels supplying blood to the heart muscle itself, experience a brief but measurable reduction in flow. More demand, less supply. That is phase 1. In the second phase, when the straining stops and you take your first breath in, the blood that had been backing up behind the compressed veins returns to the heart in a sudden rush. Cardiac output surges. Blood pressure swings sharply in the opposite direction. In a young, elastic arterial wall, this hemodynamic whipsaw, pressure up then down, then suddenly up again is absorbed. The wall flexes. The sensors compensate. The system finds its equilibrium. In an arterial wall that has stiffened with age, that pressure wave is not absorbed. It is transmitted in full. And if that artery is carrying plaque, deposit of cholesterol and inflammatory material that has been accumulating silently for years, pressure wave arrives directly at the cap covering the deposit. Most arterial plaque, when stable, causes no immediate problem. Some plaque caps are structurally vulnerable. Under the right triggering conditions, Sudden pressure surge traveling through a rigid arterial wall, the cap can fracture. When it does, the body responds instantly. Clotting factors flood to the site. A clot forms rapidly. If that clot forms inside a coronary artery, blood flow to a section of the heart muscle stops. That is a heart attack, not from the plaque. From the clot that forms the moment the plaque cap cracks, and the precise conditions that trigger plaque rupture, elevated pressure, mechanical stress, a clotting system already primed and ready, all converge in the same narrow window every single morning. The cortisol surge, the overnight blood thickening, the bathroom. Think of your heart as a pump drawing from a reservoir. Now imagine someone pinches the pipe feeding that reservoir, lets pressure build up behind the blockage, and then suddenly releases it all at once. That sudden pressure release is what a Valsalva event does to the blood supply of the heart. In a young cardiovascular system, pump handles it without incident. In a system that has been running for 65 or 70 years, with walls that no longer absorb pressure and arteries, carrying deposits that have been building for decades, that release can fracture something that had been holding for years. Before I tell you what makes this significantly worse, I want to ask you something. Tomorrow morning, when you wake up and walk to the bathroom, notice what your body automatically does when you sit down. Notice the breath holding. Notice the bearing down. Most people have never paid attention to it before. Come back and tell me in the comments what you observed. I read every single one. There is one more element that amplifies this risk, and it is something almost no one knows. Most people are not conscious of the fact that they are holding their breath during straining. The longer the breath hold, the more severe the hemodynamic disruption in both phases. A sustained 30-second strain with a closed airway is a fundamentally different cardiovascular event than a brief 10-second effort with normal breathing. The instinct most people follow, to hold harder and push longer when nothing is happening, is precisely the wrong instinct. The harder you strain and the longer you hold, the larger the pressure spike and the more violent the rebound when it releases. This is not a theoretical risk. Cardiovascular clinicians and researchers have documented a consistent pattern they refer to as toilet-associated cardiac events across multiple countries, multiple decades, and multiple independent data sets. The pattern is real. It is documented. And the early morning is the highest risk window within it because the Valsalva event does not occur in isolation. It occurs on top of a cortisol-driven blood pressure peak in blood that has been thickening overnight in a clotting system that is fully activated and ready to respond. I want to tell you about a patient. I will call him Raymond. He was 69 years old, a retired firefighter from Portland, Oregon. His wife had been urging him to come in for months. He finally did, mostly to stop the conversation at home. He was in excellent spirits. He had no complaints. But near the end of the appointment, almost as a footnote, he mentioned that he occasionally felt a brief racing in his chest in the mornings. Just a flutter, he said. He had chalked it up to too much coffee. He placed a 48-hour cardiac monitor. The arrhythmic episodes appeared every morning with remarkable consistency, between 6:45 and 7:15 a.m. They were brief. They were real. And every single one followed the same window. I have been doing that same thing every morning for 69 years, he told me when I showed him the recordings. It never once crossed my mind that my body was trying to tell me something. Valsalva event itself is only part of the picture. What turns a manageable physiological reflex into a potentially life-threatening one amplifies it, and most adults over 60 are experiencing all of these amplifying factors simultaneously every morning without realizing any of them is happening. There are three compounding conditions that transform this ordinary morning reflex into a serious cardiovascular risk in adults over 60. None of them alone is necessarily dangerous. Together, converging in the same narrow window every morning, they create a combined effect that no individual risk factor would predict. The first condition is morning blood viscosity. After 7 or 8 hours without fluid, your blood is measurably thicker than it was when you went to sleep. The plasma volume is reduced. The red cells, the clotting proteins, the inflammatory markers are all present, but in a smaller volume of liquid. Blood moves more slowly through vessels that are already less flexible. And the clotting factors, more concentrated than at any other point in the day, are more ready to respond instantly if a pressure wave fractures a plaque cap. This is not dramatic dehydration. This is what happens to every person's blood every night. In a cardiovascular system that is already carrying reduced reserve, the morning thickness changes the risk profile of a Valsalva event in ways that matter. The second condition is arterial stiffness. Research published in leading cardiovascular journals and replicated across independent cohorts has confirmed what clinicians see in practice. Stiffer arteries amplify the hemodynamic impact of transient pressure events. The identical Valsalva maneuver that a 45-year-old's artery absorbs smoothly transmits its full force to a 70-year-old's arterial wall and to any plaque resting inside it. The stiffening is not disease. It is a structural change that occurs in virtually every adult, as elastic fibers are gradually replaced by collagen over decades. It is normal aging, but normal does not mean without consequence. And the cardiovascular consequence is that every morning pressure event arrives harder than it did 2 decades ago. The third condition is the medication timing gap. Most blood pressure medications are prescribed to be taken in the morning. For patients who take medication at bedtime, plasma concentrations may be at their lowest precisely when the cortisol surge is pushing pressure toward its daily peak. For patients who take medication for first thing upon waking, it has not yet been absorbed by the time they walk to the bathroom 15 or 20 minutes later. In either case, the morning Valsalva event frequently occurs at the exact moment of weakest pharmacological protection in the entire 24-hour cycle. I am not suggesting you alter your medication timing on your own. What I am asking is that you have one specific conversation with your physician, conversation I will come back to. Now consider all of this at once. A morning Valsalva event occurring in blood thickened by overnight dehydration, transmitted through arterial walls that can no longer absorb pressure, landing at the moment when blood pressure is already at its cortisol-driven daily maximum in a clotting system fully primed and active, in arteries that may have been quietly carrying plaque for years. This is not one risk factor. It is 5 converging conditions producing a combined effect that no single variable would predict on its own. Your body communicates this stress to you. The problem is that most of the signals it sends, in the context of early morning cardiovascular strain, are ones most people have been told are simply what getting older feels like. They are not. Warning sign 1. A headache that is already present when you open your eyes, before you stand, before you have coffee, before any obvious cause exists, particularly across the back of the head or at the temples. This is a recognized clinical indicator of elevated nocturnal blood pressure. Sustained overnight pressure creates vascular stress in the cerebral circulation that manifests as the headache you wake with. This is distinct from a tension headache that develops later in the day. If this is happening more than 2 or 3 mornings per week, do not attribute it to stress or poor sleep and move on. Ask your physician about ambulatory blood pressure monitoring. A 25 4-hour recording taken throughout the night. What it may reveal could be very different from the reading taken at your last office visit. Warning sign 2. Brief visual dimming or facial flushing during or immediately after straining. During the peak of the Valsalva, your body temporarily reduces circulation to circuits it considers non-essential, including the small vessels supplying peripheral vision and the face. The slight darkening at the edges of your vision, the flush in your face, these are visible external signs of what is simultaneously occurring in your coronary circulation. Many people have experienced this for years and treated it as nothing. It is not nothing. It is your body showing you on the outside what a Valsalva event looks like on the inside, in the vessels that feed your heart muscle. Warning sign 3. Heart palpitations. A flutter, a racing sensation, a beat that feels skipped or out of sequence in the 1 to 3 minutes immediately following your morning bathroom visit. This is the rebound phase of the Valsalva. The backed up venous blood returns to the heart in a wave, cardiac output surges. In a vulnerable system, produces a brief arrhythmic moment. If this is occurring regularly, it is not anxiety. It is not caffeine. It is a mechanism, and it is specific. Begin keeping a written log. Note the time. Note what you felt. Note whether it consistently follows the morning bathroom visit. That pattern, documented in your own handwriting, is among the most diagnostically useful information you can bring to a cardiologist. Warning sign 4. Morning fatigue that does not lift in the first 30 minutes of being awake, regardless of how many hours you slept. A heaviness, a fog, a morning that never quite finds its footing no matter how early you went to bed. In many cases, this is not aging. It is a cardiovascular system that spent its first waking minutes under genuine strain and is quietly spending the next hour recovering from it. 2 or more of these warning signs are consistent features of your mornings. Do not monitor it quietly from home. Bring it to your physician. Frame it specifically in the context of early morning cardiovascular stress. The tests exist. The conversation exists. What has been missing until now is the connection between what you feel and what is causing it. Here is what you can do about it. Not a supplement. Not a program. 5 free adjustments to your morning that target the exact conditions that make this dangerous. Step 1. Water before anything else. Before coffee, before standing, before you move from the bed, drink a glass of water. This begins reversing the overnight thickening of the blood within 20 to 30 minutes. The difference in osmosis between properly hydrated morning blood and dehydrated morning blood is measurable, and it changes quickly. When you drink a glass of water before the Valsalva event occurs, you change the biochemical environment in which that event takes place. 1 glass. Before anything else, that is step 1. Step 2. Sit before you stand. When you first wake, sit at the edge of the bed for 30 seconds before putting weight on your feet. The shift from horizontal to upright is itself a cardiovascular event. Blood redistributes to the lower extremities, and your heart must compensate immediately. After 60, with slower baroreceptors and reduced autonomic speed, that transition arrives on top of an already elevated pressure peak. 30 seconds at the edge of the bed gives your body time to begin that adjustment before it is compounded by movement. 30 seconds. That is step 2. Step 3. Do not force it. If elimination is not happening easily within 60 to 90 seconds, leave the bathroom and return in 15 minutes. Your body has a gastrocolic reflex, a coordinated wave of muscular activity through the large intestine that typically activates 20 to 30 minutes after waking, particularly when triggered by a warm fluid. That reflex produces elimination without effort. What requires effort is overriding constipation. Constipation is a dietary and hydration issue. not a problem to be solved with sustained straining in the highest risk cardiovascular window of day. Every additional second of breath holding extends the Valsalva duration and amplifies both phases. Leave and come back. That is step 3. Step 4. Adjust your position. A small step stool that raises your knees above the level of your hips changes the anorectal angle into the orientation your body was designed for. This is not a comfort adjustment. It is physiological. Clinical research has shown that this positioning significantly reduces the time and effort required for elimination, some studies by more than half, with no other changes to diet or routine. Less straining time means a shorter Valsalva event. A shorter Valsalva event means a smaller pressure spike and a less violent rebound. A step stool costs less than $15. It is available today. It is the most underused cardiovascular protective measure available to adults over 60. That is step 4. Step 5. Have one specific conversation with your physician. Begin measuring your blood pressure twice daily, immediately before bed and immediately upon waking, before rising or having coffee. Keep a written log for 2 weeks. If your morning readings are consistently higher than your evening readings, particularly on mornings when you slept well and feel calm, bring that log to your physician and ask specifically about ambulatory blood pressure monitoring and whether your current medication timing is protecting the early morning window. You are not asking for a change. You are asking your doctor to look at data that a standard office visit cannot capture. You have a right to that information. Each of these 5 steps does one thing. It removes a condition that makes the Valsalva maneuver dangerous. That is the whole protocol. The reflex does not need to disappear. It needs a safer environment. I want to tell you about one more patient before we close. I will call her Evelyn. She was 72 years old, a retired accountant from Phoenix, Arizona. Her daughter had practically dragged her in. She sat across from me in that slightly embarrassed way that people do when they are not sure they have a real reason to be there. She mentioned almost as an afterthought that she sometimes felt a brief strange sensation in her chest on workday mornings. Never on weekends. She could not explain the difference, and she felt slightly silly mentioning it. I placed a cardiac monitor. The episodes appeared every weekday morning between 7:05 and 7:25 with striking regularity. On weekends, nothing. On weekends, she slept later. She had coffee before she went to the bathroom. The gastrocolic reflex had already done its work. The cortisol peak had already begun to descend. The Valsalva event was still occurring. The conditions that made it dangerous were not. She started the protocol. Water first. 30 seconds at the edge of the bed, the footstool. No forcing. 11 days later, she left me a voicemail. I remember it clearly because she was laughing a little at herself when she said it. Dr. Hardee, they stopped. Whatever was happening just stopped. I feel like somebody finally handed me the instruction manual for my own body. I want to come back to Franklin. He was not unlucky. He was not a medical mystery. He was not someone who had failed to take care of himself. He was doing exactly what millions of adults over 60 do every morning. He was doing what his body felt it needed to do. He had no reason to suspect any of it. Nobody had ever told him that the arterial walls he had at 74 were not the arterial walls he had at 40. Nobody had explained that an action his body had performed safely for 7 decades was slowly becoming something different, year by year, as those walls stiffened, and his morning blood pressure climbed, and his blood grew thicker overnight, and his clotting system grew more ready to respond to the slightest provocation. He was not unlucky. He was never told, and now you have been. Tomorrow morning, before your feet touch the floor, drink a glass of water. Sit at the edge of the bed for 30 seconds. And when you go to the bathroom, do not force it. 3 things. That is where it begins. No supplement company will ever run an advertisement telling you that. There is no profit in a step stool and a glass of water. Which is exactly why nobody ever sat across from Franklin and said these words to him before. Too late. You are hearing them now. Because of that, the morning does not have to end the same way. If this video gave you something today, something you genuinely did not know before you pressed play, send it to one person over 60 who matters to you. A spouse, a sibling, a parent, a neighbor who lives alone. You may never know whose morning you just changed. Do that before anything else today. And if you are not already subscribed, please subscribe now and hit the notification bell. Every week I release content like this, evidence-based and plainly explained, for adults over 60 who deserve the full picture of what is happening inside their bodies. Because knowing is the beginning of everything.